Hello everyone, how are you, all of you?
We're doing well, thank you.
Oh, you're welcome. Yep, I just got free from my shift. It was a 15-hour shift. And now we're gonna start. Uh, yep. Let's just give me 1 second. Okay. Okay. Let me just do one thing. Epic notifications. Okay, notifications. Mm, Okay, so okay, so okay, so do you guys have any topics that you want me to cover in respiratory system? I think everything is covered. If everything is covered, then we are gonna move to the next system.
I don't think we cover pulmonary hypertension, just
Oh,
with your world.
okay. Any other topics?
Emphysema.
Emphysema was covered. I think obstructive lung
Yeah,
disease. Hmm.
yes, but I just wanted to revisit it again. Emphysema and COPD. Thank you.
Okay.
Yes, and pharmacology.
Okay, so let's start from pharma first and then we'll move to other things, right? Okay, so, okay, ideas, right? I'm just like literally sick of pulmonology and respiratory system because for the last like 1 week I have been in the ICU. I only thing I'm hearing is like asthma drugs and like H2 blockers and then pulmonary hypertension, ARDS and stuff like that. Okay, so we are gonna start from asthma drugs, right? So as I've already told you, okay. So as I've already told you, in asthma there is bronchoconstriction, right? So there are two ways bronchoconstriction can happen, right? So if you go see this thing, right? If this is a bronchial wall, right? So what is gonna happen is that these bronchial walls are gonna have some receptors, right? And we have beta receptors here, right? And we have muscarinic receptors as well, right? So when the muscarinic receptors get activated, the bronchial wall is gonna constrict. When when the beta receptors get activated, the bronchial wall is gonna dilate, right? And we want the bronchial wall to dilate, right? We want the bronchial wall to dilate, right? Okay. This is the most important thing. So how can we dilate the bronchial wall, guys, right? How can we dilate the bronchial wall? So it's very easy to dilate the bronchial wall, right? We have to get beta activators or sympathetic agonists, right? So basically we give the patient sympathetic agonists and that is going to dilate the bronchial wall. Or we can give muscarinic agonists and that muscarinic antagonists, right? And that is going to dilate the bronchial wall as well, right? So remember, we have to go against the parasympathetic system and we have to work in the favor of sympathetic system. Okay, is that clear, guys? So now comes the question, like this is a general question but this is very important, right? So if a patient is having, can all of you hear me, guys?
Yes,
Yes.
doctor.
I don't
Yes.
know why they are low. Why are the students so low today? I announced the time as I announced the time like pretty early as well, right? And I got okay, okay. So basically, if you give anything that is against the sympathetic system, what is gonna happen is that if you give anything that is against the sympathetic system, one thing is gonna happen. You are gonna get bronchial constriction, right? The biggest example of these are the beta blockers, right? Again, the biggest example of these are the beta blockers. And why is that thing so important? The beta blockers are very important, right? Due to the fact that the beta blockers are very important due to the fact that beta blockers block the sympathetic system. So whenever a patient is having heart failure or if the patient is having any problem due to which we are giving the patient beta blockers, there is a very high chance that this patient can have asthma. Okay, right? So whenever a patient is having hypertension, asthma, always consider the beta blockers. Don't give the patients beta blockers. If you are giving the patients beta blockers, we have two types of beta blockers. The one is selective, the other one is non-selective, right? So basically, we are targeting the most important receptors are the beta 2 receptors. These are the beta 2 receptors that are present on the bronchial smooth wall, right? So the beta 2 receptors are present on the bronchial smooth wall, right? Again, remember, beta 2 receptors are present on the bronchial smooth walls, right? And is the selective beta blockers only target B1 receptors. This is gonna ask again, DO world and BMS everywhere. ECFMGs, this question is gonna get asked a lot, right? So like what is being targeted, right? So remember, beta blockers target. So we have to target the beta 2 receptor or beta 1 receptor for heart and beta 2 receptors for the asthma. Okay, is that clear, guys? Any questions till now?
No, doctor.
Okay, now good. So now I have told you that there are beta 2 receptors in the bronchial smooth walls, right? So we are going to give the patients beta 2 agonists, right? So what do we do is that we give the patients beta 2 agonists. As soon as we give the patients beta 2 agonists, the patient is going to improve. Okay, the patient is going to improve as soon as we give the patient beta 2 agonists. Now we have two types of beta 2 agonists, short acting and long acting. Short acting beta 2 agonist is the short acting beta agonist is the one known as albuterol, right? And the long acting beta agonist is the solmeterol or formoterol, right? Again, the short acting beta agonist is albuterol. Now, the main problem is beta agonist is that we have done nephrology, right? So remember, whenever we give the patient something that is gonna stimulate the beta receptors, right? What electrolyte abnormality do you think the patient could have?
Hypokalemia.
Yes. Okay. So remember, whenever we give the patients beta blockers, we are gonna have, whenever we give the patient beta agonists, we are gonna have hypokalemia, right? Whenever we give the patients beta agonists, we are gonna get hypokalemia. This is very important, right? Okay. Is that clear, guys? Whenever give the patients beta agonist, the patient is going to have hypokalemia, and hypokalemia leads to arrhythmias and tremors, right? So they're going to give you a lot of these questions that the patient came for acute asthma exacerbation, or the patient has something related to asthma, and now we decided to give the patient something to control the patient's problems, right? All right. So we give the patients now. So what did we do? We gave the patients albuterol or beta agonist, and the patient's symptoms are improved. But now the patient is having muscle weakness and tremors, and then they're gonna ask, what is the most likely cause of this thing? Right? So you know, guys, you already know the most likely cause of this thing is gonna be very simple, right? It's gonna be the fact that beta agonists lead to hypokalemia, and that is gonna cause tremors and arrhythmias, right? Now remember, albuterol is short acting. Whenever you have acute symptoms of asthma, you're gonna give albuterol. Similarly, if you are having acute system of COPD, you're gonna get albuterol as well, right? You're gonna give albuterol as well, right? But if you have something chronic, right? If you have anything that is chronic, then you are gonna give the patient solmeterol or formoterol, right? Okay. Any questions till now, guys? I know it's a lot, like I'm throwing a lot of things at you, but this is important, right? Any questions, guys? Any other questions? Okay. Now let's move to the other thing, right? So remember, asthma is due to two problems. One is the beat. One is that these receptors are gonna get activated. The other thing is that whenever the body is gonna get an allergen, right, or the body is gonna get anything, there is gonna be inflammatory response. What does inflammatory response mean? It means that neutrophils, macrophages are gonna come here. These neutrophils and macrophages are gonna destroy the wall, right? They're going to secrete substances, there's going to be edema, there is going to be blockage, and then you're going to have a lot of nasty stuff that is going on, and all of this thing is going to get blocked, right? All of this thing is going to get blocked. Okay. So this is what happens in case of asthma, right? So now the second thing that is very important is glucocorticoids or steroids, right? Why? Because steroids inhibit the secretion of cytokines. What are cytokines? Cytokines are the stuffs that neutrophils, macrophages secrete, right? So they do all of their dirty work with the help of cytokines, right? So just think of neutrophils or macrophages, right? So neutrophils or macrophages are like the policeman, right? And if you look at if you look at any country, right? If you look at any country, you are gonna see that especially the politicians, they have if they want to do anything good as well, if the police is gonna don't do anything good as well, a lot of times they don't do it directly, right? They have hired goons, or they have hired people, private military companies or private things that are gonna do those things, right? So these private things are known as the cytokines, right? So neutrophils and macrophages secrete cytokines, right? These cytokines do all of the dirty work of neutrophils and macrophages, right? So what do steroids do? Steroids go there. Steroids inhibit the synthesis of virtually every cytokines, right? It's gonna inhibit nuclear factor K beta, right? Remember this. This is asked a lot. Nuclear factor K beta, right? Nuclear factor K beta is gonna get blocked, right? Nuclear factor K beta is a transcription factor that produces all of the cytokines, right? So no cytokines is gonna be produced. When no cytokines is gonna be produced, right? What is going to happen is that neutrophils and macrophages are not going to cause any problem. This is how basically steroid work in every single place in the body, right? If you are having any immune problem, just give the patient steroids. No more cytokines, no more problem, right? Any immune problem, successfully, Why is absolutely happening? Because neutrophils, macrophages, they are going to secrete antibodies, they are going to secrete cytokines, right? You are immunosuppressing the hell out of the patient because basically you are cutting the leg and arms of neutrophils and macrophages, right? It's just like you have a very nice car, you have the best car in the world, but I just take the wheels of the car out, right? What are you going to do with that car? And if your car, I just took out all of the petrol of the car. So this is how steroids are going to work. So remember, the most important thing regarding steroids is the fact that steroids so the most important thing regarding the steroids is the fact that steroids are the first line for chronic asthma, right? The second thing is that there are some side effects of the steroids. So basically, steroids are going to immunosuppress your mouth as well because you are going to take it by spacer or rinser, right? So when your mouth is going to be having problems, what is going to happen eventually, right? Okay, so steroids are going to cause problem to your mouth, right? And when you're going to get mouth problems eventually, the thing that is going to happen is that you are going to get thrush, right? You're going to get oral thrush. Is that clear, guys? Okay, you're going to get oral thrush. Okay. Now, the next thing that is important is, so remember, the most important side effect of LB inhaled or oral corticosteroids are oral thrush, right? And if you use a spacer or insert, then that is going to prevent oral thrush, right? Just give me a second, guys. Just give me 1 second. Okay, so now let's move to the next one. So next one, the muscarinic antagonists. They are two, tiotropium and mitratropium. I've already told you, if you have to block the muscarinic system, right? There are two ways you can block it, right? Tiotropium or ipratropium, right? So tiotropium is long acting. Again, ipratropium is short acting, right? We mainly use muscarinic antagonists in COPD. Remember, they are not used in asthma. In asthma, we use inhaled beta agonists. We use a sympathetic agonist. We do not use a muscarinic antagonist, right? Now let's move on to the next one, which is leukotrienes. Right now, let's focus on leukotrienes. So, what are leukotrienes? Okay, so basically, we have arachidonic acid. Right. So the thing that is arachidonic acid. Arachidonic acid can form a lot of things. Right. It's gonna form the PGEs. Right. It's gonna form the leukotrienes. Right. Now, what happens is that these leukotrienes are the LTC4, D4, and E4, right? So LTC4, D4, and E4, they what do? They basically so LTC4, LTD4, and LTE4. These three leukotrienes are going to do one thing, right? They are going to cause bronchospasm. They are going to cause bronchoconstriction, right? LTC4, LTD4, LTE4, they are going to cause bronchospasm, right? Normally, they are not very important. We do not use them normally in the treatment of asthma. Okay. Again, I'm telling you, you do not use leukotrienes normally for the treatment of asthma. Right. Okay. So when do we use them for the treatment of asthma? So let's go on the arachidonic acid pathway. Okay. Okay, so basically this was arachidonic acid, right? So this was arachidonic acid. Arachidonic acid get converted into leukotrienes, or it could get converted into thromboxanes, prostaglandins, right? Okay, so what happens is that in some patients who are very sensitive to asthma, if you give those patients aspirin or NSAIDs, right? If you give those patients aspirin or NSAIDs, what is going to happen is that aspirin or NSAIDs are going to block this arachidonic acid place, right? Okay, so aspirin and NSAIDs are gonna block this thing. This is gonna get blocked. Is that clear, guys? So now, if this area gets blocked, where do you think every other thing is gonna go?
Yes. Opposite sides.
Yeah, so it's gonna go to the leukotriene
Yes.
side.
Yes.
Okay, so it's gonna go to the other side, right? And what is the other side? The other side is leukotrienes, right? So we are gonna have these leukotrienes here, right? We are gonna have these leukotrienes. It's gonna go here, the leukotrienes. Okay, it's going to go to the leukotrienes, right? And then these leukotrienes are going to cause a lot of problems. Similarly, when you are exercising, the cyclooxygenases are going to not be produced, right? And leukotrienes are going to be produced more. So in these two things, in exercises induced asthma and in aspirin induced asthma, these are the only two places where we use leukotrienes. And you have to understand why do we use leukotrienes and inhibitors in those two places, right? Right? Okay, this thing is known as the 5-lipoxygenase, right? This area is known as the 5-lipoxygenase. So 5-lipoxygenase is gonna make leukotrienes. So we can do two things. One thing is that we can inhibit the 5-lipoxygenase with the help of xylutone. So xylutone is an inhibitor of 5-lipoxygenase, right? And when xylutone is gonna be inhibited, what is gonna happen is that, right, so whenever the xylutone is going to be inhibited, right, yeah, in the life 5 prime lipoxygenase is going to be inhibited, no more leukotrienes is going to be produced. Other thing is that these leukotrienes are going to act on a receptor, right, on the bronchial smooth muscles, right. So these are the leukotrienes, so these are known as the cyst lt1 receptors, right. So it's going to act on the cyst lt1 receptors. Okay, so it goes and works on the cyst lt1 receptors, right. And then when it works on the cyst lt1 receptors, what is going to happen is that, well, whenever it works on the cyst lt1 receptors, you're going to have one thing, right. You're going to have bronchoconstriction. So we have two other things which is known as zafirleucest and monteleucest. Monteleucest, we are going to use this to prevent asthma, right. So we are going to use monteleucest and we are going to use zafirleucest as well. Okay, so these are the leukocyst-1 receptor blockers, and that's going to solve the exercise-induced asthma and aspirin-induced asthma. So Cox. Yeah, not really. We have a lot of prostaglandins in the body, right? And we have very few like leukotrienes, right? So body can handle a lot of prostaglandins. They can go every single way. It's not gonna cause any problems, right? So remember, it's a reproductive questions, right? But it's a very important question, right? So the woman of, like, if we look at a girl, right, and if the woman's age is between 18 to 25, right, especially at into 25, you are gonna see that these women have periodic pain, right, in the lower abdomen, right, and in that radiates to the pelvic area, right. This pain is known as the pain of primary dysmenorrhea. A lot of women, especially these days, it's very prevalent in females, right. So primary dysmenorrhea is very prevalent in the females, right. And regarding this arachidonic acid pathway, primary dysmenorrhea is very common in females, right? There's a lot of pain. The pain is in central area. It does not radiate to the right or left leg. It just stays in the pelvic area, right? And sometimes it causes increased bleeding as well, right? This is known as primary dysmenorrhea. And for the treatment of primary dysmenorrhea, the first line thing is NSAIDs, right? Why? Because primary dysmenorrhea is caused by prostaglandins, right? It's caused by prostaglandins, these two. So if we block so what happens is that if we block the formation of prostaglandins, the primary dysmenorrhea is going to go away, and it's the most effective treatment of primary dysmenorrhea. Okay, is that clear, guys? Now, one other thing, aspirin is going to block the formation of thromboxanes and prostacyclins, right? Any questions regarding this? Any questions? Okay, so why do we use? Okay, so fun fact. Now we have two things. Thromboxane and prostacyclin. Thromboxane causes coagulation, right? And prostacyclins cause anticoagulation or dilation, right? So what do we require in a normal person? Do we require, especially in a patient whose age is 45, he's diabetic, right? Do you think he's having heart failure? What do you require in this patient? Coagulation or anticoagulation?
Anticoagulation.
Anticoagulation. How can we achieve this anticoagulation? By giving aspirin. How does giving aspirin improves anticoagulation? Mm.
Orexin receptor.
No. How do we increase improve anticoagulation with aspirin, right?
It reduces the thromboxane production.
So it's gonna block the prostacyclin's production as well. Why? Why specifically that?
It inhibits platelet aggregation.
Hmm?
It inhibits platelet aggregation, I think.
Okay. How? That's okay.
Forgot.
Okay, so basically it's gonna block both platelet formation and endothelium formation, right? But the most important thing is that this thing is reversible, right? This is irreversible. Once the formation of thromboxane is blocked, it's gonna be blocked for like 7 days or so. But prostacyclins are gonna regenerate themselves. They have the ability to regenerate themselves. So you're gonna have more anticoagulation effect, and the coagulation is gonna be gone. That is why it's gonna cause this, and this is asked a lot, right? What's the difference between aspirin and every other NSAID? What's the difference between aspirin and any other NSAID? Can you anyone tell me? Anyone?
That isn't reversible.
So aspirin is irreversible, right? Aspirin is irreversible. Okay. Is that clear, guys? Okay, so aspirin is irreversible. Okay, let's move forward. Now we are done with anti-leukotrienes, and now let's move to the anti-IgE monoclonal antibodies, right? So basically, asthma cells are gonna secrete IgE as well, right? IgA is an antibody that is gonna cause asthma as well. So if you just could make we have a monoclonal antibody, it's gonna bind to Ig and it's kind to Ig. The Ig is not gonna bind to anything, right? So we use in those patients who do not have any response to beta blocker and glucocorticoids. It's the last line therapy. Remember, for any disease, biologics are the last line therapy, right? Okay. We for anything, right? Anything, biologics are the last line therapies, right? Is that clear?
No, I don't understand. Can you go over it again?
Okay. 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 I'll go over it again, right? So basically, we have what are biologics, right? So what happened was that scientists started to make new molecules, right? Scientists start making new biologic molecules, right? Scientists started making new biologic molecules, and what did they see was that the fact that these molecules can bind to the molecules that are present in our body, and when they bind to these molecules, the body is going to have a very different response. The body is very better, right? So, but these are very expensive, right? These biologics are very expensive, right? So basically what you can do is you can if there is one substance in the body, right, that is causing a lot of problems, you can just artificially engineer a substance, and this substance is going to bind to the substance that is causing the problem and get the hell out of and make it disappear, right? So for example, TNF alpha, it causes Crohn's disease, right? We have made a thing which is known as adalimumab, right? Adalimumab is going to bind to it, it's going to cause the Crohn's to go away. Similarly, there are VEGF inhibitors, right? So what is VEGF? VEGF is a protein that is going to form blood vessel in eye, right? VEGF leads to blood vessel formation in eye, blood vessels in eye. So whenever a patient is having uncontrolled diabetes, VEGF is going to be increased. There is going to be diabetic retinopathy, right? Again, there's going to be diabetic retinopathy whenever it's going to be increased. Okay, is that clear, guys, to you?
Yes, yes.
Okay, so basically these are specialized molecules. There are two side effects of specialized molecules. What are those side effects, right? So those side effects are let me tell those side effects. One side effect is that it's extremely expensive, right? It's extremely expensive. Okay, it's extremely expensive. These keep this thing in mind. So this is the first thing, right? What's the second thing? The first thing was that. Second thing was that. Okay. So second thing was the fact that these are usually used as last lines, right? Because they are gonna cause a lot of problems, right? So just keep this that these are extremely expensive, so we can not give the get these. You cannot give these to everyone, right? Is that clear, guys? Okay, now let's move forward, right? So omalizumab is a protein that is going to bind IgE, right? Omalizumab is a protein that is going to bind that is going to go to IgE, right? It's going to bind IgE, right? And when it binds IgE, right? So you're going to have the problems. Okay, is that clear, guys? You're going to have the pro solutions. Is why is everyone so quiet today? Right? Okay, now let's move forward, right? Similarly, basically we have a thing which is known as the phosphodiesterase, right? So what does phosphodiesterase do? Can anyone tell me what phosphodiesterase does?
Inhibiting phosphodiesterase 5.
So what is phosphodiesterase? What does phosphodiesterase does?
It breaks down cyclic AMP to
Yeah,
sort of, yeah.
exactly. So it breaks down cyclic AMP, right? So phosphodiesterase basically just breaks down the cyclic AMP, right? Cyclic AMP causes muscle dilation, right? Cyclic AMP causes muscle dilation, right? So what if I tell you a patient is having asthma, right? And this is the bronchial muscles, right? Do we need more phosphodiesterase or less phosphodiesterase right now?
We want to
Less.
dilate, so we want to
More. We need
uh,
more.
More.
we need
Need more.
So we need more phosphodiesterase.
Less,
Just
less.
Less.
We
We
need
actually
less.
Only
recommend less.
less. Less.
yeah. So
Less
we need less. So
phosphodiesterase
we
so that
have no. So we
AMP
need less
can.
phosphodiesterase exactly. And in order to get less phosphodiesterase, what do we do is that we start using phosphodiesterase inhibitors, right? It's very simple. We start using phosphodiesterase inhibitors. And when you start using phosphodiesterase inhibitors, right, the CMP levels are going to increase, right? And when the CMP levels are going to increase, you're going to get everything under control, right? The bronchial muscles are going to dilate, right? The theophylline causes is a phosphodiesterase inhibitor. It's going to increase CMP levels, right? CMP level is going to cause increased amount of bronchial dilation. Why don't we use theophylline a lot? Because theophylline, we need to break. Yes, yeah, I got it. So COPC, phosphodiesterase are two side effects. It's gonna cause seizures, neurotoxicity, and it's gonna cause arrhythmias. So seizures and arrhythmias, right? It's gonna drive the heart and the brain crazy. So it's gonna break the heart and the brain crazy, right? Is it clear? It's
Yes.
gonna okay. So it's gonna grow. It's gonna drive the heart and the brain crazy. Okay, so these are the most important side effects. Please keep this in mind because they're being asked a lot, right? They're gonna get asked a lot, right? Uh, you and me is love these questions on the theophylline, right? Now the next is PDE4 inhibitors, right? PDE4 inhibitors again are phosphodiesterase inhibitors, right? They're gonna cause phosphodiesterase. They're gonna cause bronchodilation, right? They are used in COPD, right? Then we have the chromons, right? We do not use it anymore. Just skip this thing, right? Just skip this one, chromons. Okay. Now, finally, we have some other biologics as well, right? Okay, so but before biologics, let's just complete every other thing because I don't think so biologics are that important and I don't want to waste a lot of your time on the biologics, right? Okay, okay. So let's move to the next thing. Oh my God. Any questions till now, guys? I'm up for answering any questions.
Please, if you could explain about the lung volumes.
Okay,
I think. Mm,
okay. Anything else?
Doctor, you explained that part, but I couldn't understand that with aspirin and the prostacyclin. I understood the thromboxane part, but I couldn't grasp that aspirin and prostacyclin.
Okay, I'll explain it again. Right, this is important. I will explain it. Just give me 1 second. Okay, so what is okay? So let me tell you. Right, let me tell you what is happening. Right. So, what Friends, can we explain if possible? Okay, I'm writing these questions down. Let me first finish this H1. Okay, then we're gonna complete, right? So what are H1 blockers, right? So H1 blockers are antihistamines, right? What are those? What are those gonna cause, right? So what do histamine receptors? What are antihistamines are gonna cause, right? So basically, why do we use H1 blockers, right? We use histamine blockers because histamine is gonna cause edema as well. They are gonna cause runny nose as well, right? They are okay. So mainly we use it for allergies, right? So whenever there is allergy, if a patient is having any sorts of allergy, that patient histamine levels are going to be increased. So what do we do? That if a patient is having allergy, if a patient has pollen allergy, so if the person say that the 30 or 25-year-old female comes to you, and that female is having that female is having sneezing, that female is having a runny nose, that patient is having a lot of these things, right? And we start the patient on antihistamines, right? How is that gonna treat the patient, right? So what is gonna happen is that if you're gonna give the patient antihistamines, what is gonna happen is antihistamines basically control the allergies because histamines are needed for the secretion of uh, molecules in allergy, right? So this is the main use of antihistamines. Now we have two types of antihistamines. One is the first generation, the other is the second generation, right? You World and NBMS love to test you on the concept that when do we use the first generation, when do we use the second generation, right? So basically, we use the first generation antihistamine whenever again explain okay, so whenever so when we're going to use a first generation antihistamine cause sleepiness, right? Why? Because first generation antihistamines cross the blood brain barrier, right? As soon as they cross the blood brain barrier, they are going to cause a lot of sleepiness. Okay. Well, now let's move on to the second generation. Second generation antihistamines don't go into the CNS, so they don't cause any kind of sedation, right? So if we need sedation as well, right, we are going to give first generation antihistamine. If we do not need any sedation, we are going to give second generation antihistamines. Is that clear, guys?
Yes, doctor.
What are the other uses of first generation antihistamines, right? The second thing is that so first generation antihistamines crosses the CNS. When it's gonna cross the CMS, it's gonna go to the vestibular center or the vomiting center. This vomiting center in the brain, and it's gonna stop the vomiting. Right. Second thing, whenever the first generation antihistamines grow to the brain, right, they are gonna cause sleepiness, right? Other, so we are gonna use it as sleep aid as well, right? Other things, right? If now sometimes whenever you're going to some hilly area or whenever you're driving a lot, right, or there's bumpy road, right, or if you are go off or got sick, stuck with a driver who is driving very rash and fast and everything is moving very fast, what is gonna happen is that you are gonna get motion sickness, right? And this motion sickness is gonna be due to vestibular centers that are gonna be in the brain, right? So how can we prevent this motion sickness? In order to prevent this motion sickness, we can do one thing, right? What can we do to prevent the motion sickness? So in order to prevent the motion sickness, we can give the patients antihistamines, right? As soon as we give the patients antihistamines, they are gonna go to the vestibular centers in the brain and motion sickness is gonna be controlled, right? Okay. Now, uh, let's okay. So second generation is only used for allergies, right? Now we have dextromethorphan, right? What is dextromethorphan, right? Dextromethorphan is an antitussive, right? So basically, dextromethorphan is going to just do one thing, right? It's going to act on the glutamate receptors, NMDA glutamate receptors, right? And then it's going to control the coughing, right? So what is most important regarding it? I saw a patient today, right? So I saw a patient and that patient was on serotonin, right? I'm not going to give a lot of details, right? I am not allowed to, but that patient was on serotonin, right? And when the patient was on serotonin, so she was being treated for depression, right? And all of a sudden she had a cold, right? And when the patient had a cold, right, then the amazing thing that happened to that patient was somebody prescribed her a dextromethorphan, right, for just the cough, right? So the patient said, I wanted to deal with the cough, right? So she was prescribed a dextromethorphan, right? And when you combine it with a dextromethorphan, right, what is going to happen is that it has mild serotonergic effect as well. So you're going to get serotonin syndrome, right? What is serotonin syndrome? We are going to go into the detail of it during psychiatry, right? But remember, whenever a patient is on any serotonergic drugs, do not give the patient dextromethorphan. People do not, people underestimate this thing, but this thing is very important. Okay, please keep this thing in mind. You're gonna get a lot of questions on dextromethorphan and serotonin. So basically, let me give you a brief overview of serotonin syndrome. In serotonin syndrome, there is gonna be hyperreflexia, there is gonna be clonus, there is gonna be diarrhea as well, right? So hyperreflexia, clonus, and diarrhea. Okay, is that clear? Now, let's move to pseudoephedrine and phenylephrine. So, what are pseudo? So basically, what receptors do the blood vessels have? Anyone?
Alpha receptors.
Okay. So blood vessels have alpha receptors and beta receptors both, right? So whenever the alpha receptor is activated, you get uh, you get constriction of the blood vessels, right? So if we need less edema at any place, right? If we need, so if we have a runny nose, for example, if we have a runny nose, why do we have a runny nose, right? So we get a runny nose whenever the blood vessels dilate at a place, right? So if we need to control runny nose, what we can do is that we can give a drug that constricts the alpha receptors. As soon as we give a drug that constricts the alpha receptor, there is going to be less blood flow to the nose. When there is going to be less blood flow to the nose, right, all the runny nose is going to go away, right? Okay, so basically we use it to open eustachian tubes to treat the runny noses. But how is this going to be tested in the exam? They want to test this only in one concept, right? The concept is that phenylephrine is going to treat the runny nose in like 30 minutes or even less than that, right? But the fact is, if you use it for more than 4 to 6 days, right, you're gonna, when you stop using it, you're gonna get rebound congestion, right? Because it's due to the sensitivity effect. I'm gonna explain the sensitivity effect in the journal pharma, but keep it in mind, right? So you're gonna have their sensitivity effect, and it is gonna cause a lot of problems due to that. Okay, so you are gonna get rebound congestion, right? And when you are gonna have rebound congestion, that thing is known as the rhinitis medicamentosa, right? Rhinitis medicamentosa, right? So you're gonna get rhinitis medicamentosa due to uh, phenylephrine and pseudoephedrine. Okay, now let's move to pulmonary hypertension drugs, right? So again, first of all, why does pulmonary hypertension happens, right? So pulmonary hypertension, the main cause of pulmonary hypertension is we get a we'll get a molecule which is known as endothelin, right? So like norepinephrine and epinephrine. So where do norepinephrine and epinephrine work, guys? Anyone? Anyone? Where does norepinephrine and epinephrine work?
What's the question, doctor?
Hmm?
Alpha,
Again?
What do you
alpha,
understand the question?
alpha one,
On which
beta one,
receptors do epinephrine and norepinephrine works?
alpha one, beta one,
Alpha and beta both.
Okay,
alpha.
so yeah, so when it
Alpha and
works
beta.
on the alpha receptors, what is gonna happen is that you're gonna get constriction, right? Similarly, in the pulmonary vessels, there are no alpha receptor, beta receptors, they are endothelin receptors. And when endothelin receptors get activated, you are gonna get constriction. It's very simple. Okay, so now and endothelin receptor antagonists, which are bosentan, they are used to antagonize those, and then the pulmonary vessels are not going to get constricted and they are going to get dilated. Okay, similarly, we can give the patients PDE5 inhibitors, right? They're going to inhibit phosphodiesterase 5, so cGMP is going to increase and it's going to cause the pulmonary vessels to dilate, right? We also use it for erectile dysfunction as well. Why do we use it for erectile dysfunction? Because in erectile dysfunction, we have blood vessels, right? So how does the penis get erected? So any penis gets erected whenever the blood vessels get dilated, right? So whenever the blood vessels get dilated, a lot of blood is going to come into the penis and it's going to get dilated, right? So whenever a patient is having erectile dysfunction, there's a lot of causes of erectile dysfunction, right? So maybe you could have some kind of psychiatric problem, right? Where your brain is not able to send, your brain is so traumatized, your brain is having such problems that your brain is unable to send signals to the blood vessels in your reproductive organs, right? And the blood vessels are not dilated, right? Similarly, you can have diabetes, right? And there is atherosclerosis in the blood vessels. So now the blood vessels cannot dilate and there is arteriosclerosis, right? These are gonna cause a lot of problems. Okay, so how can we treat that? We can treat that by giving the patient sildenafil or phosphodiesterase 5 inhibitors. What is sildenafil and phosphodiesterase 5 inhibitors going to do? They are going to increase CGMP. CGMP is going to cause smooth muscle dilation, and the erectile dysfunction is going to be treated. Right? I have already told you why don't we give nitroglycerin with sildenafil, right? Right, it's going to cause hypertension, right? And I've explained in very much detail how is that going to happen. Last thing is that prostacyclin analogs, right? So prostacyclin analogs directly affect the pulmonary vessels and it's going to cause vasodilation, right? And other thing that I've already told you guys, it inhibits platelet aggregation, right? Prostacyclins is going to inhibit platelet aggregation, and when platelet aggregation is going to be inhibited, you are going to get anticoagulation effect, right? And we need that anticoagulation effect, right? So once someone asked me the question, why prostacyclin, why, how does aspirin help with anticoagulation, right? So aspirin blocks the production of two products, right? First is prostacyclin and the other is thromboxane, right? So prostacyclin is very good, right? They love us, right? So whenever aspirin blocks the formation of prostacyclin says, "Don't worry, I'm gonna find a way and I'm gonna come back to you," right? Prostacyclin says, "Don't worry, I'm gonna come back," and prostacyclin comes back, right? And when prostacyclins come back, right, they are gonna cause anticoagulation, right? But thromboxane is a mean molecule. Thromboxane does not come back. So thromboxane does not come back, but that's good for us, right? Why is that good for us? Because now we are gonna have anticoagulation effect. That is why we always give any patient who is having suspected MI or who we think could have MI in the future or stroke in the future, thromboxane and aspirin, right? And they could ask you how do these molecules act, right? So please remember always pharmacology is very important, right? Pharmacology is very important. Please always pay a very good uh, pharmacology, physiology, pathophysiology, all of these things are important. Okay, especially pharmacology. Okay, so that is it for today, guys. Right. Uh, uh, Believe me, it was very, very hard for me to give this lecture today, right? So I went for like 7 in the evening, right? And I came back 10 in the morning, right? So it was from 7 p.m. EST to 10 a.m. EST, right? So I think it was like we maybe, I don't know, it's a 15-hour shift, right? But yeah, I want you to complete this session, right? I'm gonna complete all of the marathon with you guys, right? I think most likely we are gonna start immunology, right? If there are any topics left, maybe we can do those topics first. Okay, right? I
Are
think I do.
from Patoma or FA?
What? What? What?
Immunology, are we gonna do it from Patoma or
Yes. So
like
I personally like first aid for everything, right? Right, you can do everything from first aid, right? But again, that's a personal preference, right? That's a personal preference. You could go it from first aid or like you could go it from pathoma, right? It's up to you. But for me, I would say I like first aid, right? So first aid is better for me, right? But yeah, yes, study everything from first aid, but like not like only from first aid, right? So you're not just gonna say like I have learned first aid, I am gonna get like I'm gonna ace the USMLE. Know what is written in the first aid. What does first aid means, right? Why can't we give sildenafil with why can't we give two nitrates together, right? How is aspirin gonna increase the level of prostacyclins, right? What's the difference between aspirin and other NSAIDs, right? Aspirin, first aid mentioned things but not in a lot of detail, right? The detail you have to gather it, right? You have to gather the detail, and that is gonna cause you to get good marks, right? Not just the fact that the memorization is. So I have this formula, right? So Einstein was the greatest genius ever, and he gave us the best formula ever, right? So he told us that E is equal to mc square, right? So E is your steps. So E is your step scores, right? So E is your step scores, right? And M is equal to memorization, and C is equal to concepts, right? Uh, so, and you have to have a square of that, right? If your memorization is zero, you're not gonna get anything, right? But if your memorization is like 0.6 or 0.7, right, and if you have good concepts, that are gonna get amplified a lot, right? Your good concepts are gonna do yeah, yeah. So you have to do the memorization part. I'm helping you with the concepts part because there is a concept square, right? It's gonna help you a lot in the long run, right? So why do we give? So here it's written, right? We give aspirin for an aspirin induced asthma, and like aspirin induced asthma and exercise induced asthma, we give anti-leukotrienes, right? But why, right? You have to understand the whys. These whys are important, right? Okay, guys, so take care. I'm gonna sleep now, so bye bye. Okay. Okay, you're welcome. Bye bye. Bye bye. Thank you
Thanks.
so much.
Thank you so much.
No, you know,
Bye.
you're
Bye.
bye bye. Bye bye.